So, given the release of his groundbreaking report, the first Surgeon General's report on addictions, we know our next guest is with us. Surgeon General Dr. Vivek Murthy has put the full weight of his considerable intellect and his office on understanding and addressing our nation's public health crisis. He is the son of immigrants from India, and he discovered a love of the art of healing when he spent time in his dad's medical office in Miami. He's a scientist that believes in wellness and being the third pillar of health, and that we need to really take care of our own emotional well-being. And he's a yoga practitioner, but he does admit that his guilty pleasure is bread pudding and buttermilk biscuits. Really? I don't know, maybe he'll tell us something different when we ask him. This morning we have a chance to talk one-on-one with our accomplished Surgeon General. Please join me in welcoming him. Thank you so much for being here. Murthy? Well, I'm thrilled you're here.
Thank you. I'm glad to be here. How's everyone doing today? There we go.
And he's charming, too. I mean, that's a great combination. Now, I've actually heard you speak, and I know how good you are and how connected you are to these topics. But we have a few questions that I want to start with. And this is very simple, and people in the audience may know the answer, but I really don't. Are you in the military? You have a uniform on.
Well, you're right. I do have a uniform on. But I'm in one of the 7 uniformed services of the United States government. Many people are familiar with the Army, the Navy, the Air Force, the Marine Corps. Many people don't know that we also have the United States Public Health Service, and that's the uniform that I wear. And the United States Public Health Service Commission Corps comprises about 6,600 officers who are in a variety of public health and medical disciplines. They include doctors and nurses, pharmacists and physical therapists. And in their day jobs, they work on advancing public health in communities in 800 locations around the country and around the world. But they also deploy during times of emergency. When we had the Ebola crisis, we sent hundreds of officers to Liberia to set up the Monrovia Medical Unit, which cared for Ebola patients. During the Flint water crisis, we deployed officers there. During Zika, we sent many officers to Puerto Rico and other parts of the country to assist in the response. So both on a day-to-day level and also during acute emergencies, our officers are the ones who respond and help to provide care to communities and also help to strengthen the public health infrastructure.
You know, that's very helpful. And I think it's helpful for maybe a reason that's not directly related, but it sounds like something we should encourage young people to think about.
Absolutely, and thank you for being part of our recruitment pitch.
Yes.
Appreciate that.
Yes. No, I'm serious about that.
You know, when I was actually about 12 or 13 years old, when I was in middle school, I traveled to visit my aunt and uncle in Ohio. And I remember my aunt worked in NIOSH, which is one of the federal agencies, and she worked with Commission Corps officers. And she told me back then, she said, you should think about joining the Public Health Service. And it never quite happened for me until I was honored to be appointed as Surgeon General. So I called her about 30 years or so later, and I said, it took me a while, but I finally got here. I'm part of the Commission Corps. But it is a great career pathway for young people who are interested both in health, but also in serving your community and getting a diversity of experiences around the country and even around the world. So for anyone who's out there who has kids or students who are interested in a career in health, please encourage them to think about the Public Health Service Commission Corps. It's a great career path.
Nice, very nice. So let me ask you another question about that. So I know you were appointed. How long do you serve? Is it a term limit? Or do we get to vote for you again?
Well, it's not an elected position, it's an appointed position, and it's a 4-year term that the Surgeon General has. It runs independent of administrations. Okay. My term began in December 2014, and it will technically end in December 2018.
Great. So we have time to really learn from the wonderful report that you put together. So one of the things, the minute I saw the title of it, and we were really anxiously awaiting it, we were calling Tom, who worked for SAMHSA and worked, I know, on helping some of the organizing. We would call him every other week and ask him how it was going, and could we get you to the conference? So thank you for being here. And it's called the Surgeon General's Report on Alcohol, Drugs, and Health. Was that purposeful, that it also has health in the title and didn't just say drugs and alcohol?
It is purposeful. I mean, with many of our reports, what you'll see is health is included in the title because it's just a reminder that that is ultimately our objective. It's to think about health really from two angles, both how do we prevent factors from coming into play, like drugs, for example, like opioids in particular, but how do we prevent these factors from coming into play that can harm people's health? But it's also a reminder that we have to think about the other side of the equation, which is how do we promote health? We can't just be thinking all the time about how to remove risk factors. We also have to be thinking about how to actually promote health. And this comes back to an idea that I think about very often in this job, which is that health is really on a spectrum. And we think about disease on one end of the spectrum and a very high level of functioning and wellness on the other extreme of the spectrum. In the middle point, you have a state where you can be disease-free, but not necessarily be functioning at the top end of your scale.
Right.
And for too long, we have thought about health as just being aimed at eradicating disease.
Yes.
But if all we do is eradicate disease, we will make a lot of progress, but we'll ultimately just get people to be disease-free. That doesn't necessarily mean that they are operating on the highest end of their scale. But we really need to look at the entire picture. So for us, we include health in titles. We think about wellness a lot because we want to get people from one end of the spectrum all the way to the other.
So could you talk a little bit about the report and prevention? You know, we're spending so much time, when I opened, I talked about the epidemic and people wanting this just fixed. Mm-hmm. And we know it isn't that easy. And so what does the report say about prevention, and in the audience, we have a lot of people who run organizations, they're mental health, addiction specialists. What should we be doing on the prevention side?
Well, the bottom line is, when it comes to substance use disorders, prevention works, it's cost effective, and it's very underutilized. And that's the gist of what the report says. It lays out, though, in great detail, in an entire chapter dedicated to prevention, programs that have been proven to work. It actually does a cost-benefit analysis of these programs as well. It shows that we have some prevention programs that save up to $64 for every $1 invested. And that's savings in healthcare costs, in lost productivity, and in reduced criminal justice system costs. And I'll guarantee you, if you went to anyone and said, I'll give you $64 for every $1 you give me, that's a pretty good deal. It's a good investment.
Private equity probably to invest in it.
But the problem is we don't see these programs being utilized nearly as much as they should. And some of that's because people don't know that we have evidence-based prevention that actually works.
Give me one example of an evidence-based program, that you think is one that is really relatively simple, will save money, and if we're going to go do one thing, when I'm talking to our members, I'm going to ask them, what should I be asking?
Well, there are a number, and we actually lay them out, but the Good Behavior Game program, which many of you I'm sure are familiar with, is a school-based program. It's actually the one that returns the $64 that I mentioned for every $1 invested. And the fact that it's a school-based program is actually irrelevant, because something that many of the members who are here today know is that starting early when it comes to prevention is incredibly important. Yeah. The adolescent brain is at a delicate stage during those years, and it's very susceptible to the harmful effects of substances of misuse, like alcohol and drugs. And we know that when kids start using, whether it's alcohol or illicit drugs at an early age, then their likelihood of developing a substance use disorder is greater. We know, for example, when you look at illicit drugs, that kids who start before the age of 13 have a 70% chance, or the 70% of them actually will go on to develop a substance use disorder later in life, compared to kids who first try illicit drugs after the age of 17. Only around 25 to 27% of them will develop a substance use disorder later in life. So working on prevention programs that target kids in particular, that's especially important. And that's why programs like the Good Behavior Games Project are so helpful.
So as you were doing this report, what surprised you? I'm going to tell them a little bit about your background. You are very well educated. But was there something or a few things that really were, I didn't know this, or wow?
Well, there were several things actually that were really striking to me. And let me just tell you that I did this report for a couple of reasons. And one is obviously we all know the numbers, and we know that, well, we don't all know the numbers. Let me be clear about that. One of the reasons we did the report is because the country doesn't, in fact, understand the entire scope of this crisis, and we wanted to change that. But we've known and heard about the fact that addiction is a problem in America for a while now. But I had really seen it from the earliest days in medicine that this is a problem that was not only underappreciated, but that we as clinicians were underprepared to actually address. And if you were to tell me that the majority of patients that I saw either were directly or indirectly affected by a substance use disorder, I wouldn't have believed that because my medical training didn't reflect that. So I really learned the hard way that there were gaps in my education that I had to fill because my patients had needs that I had to be able to meet. So I remember that as I was going into this job, and in fact when I was leaving my hospital and I stopped by to say goodbye to the nurses that I had worked with for years, ever since I was an intern in fact, they had one request from me. They said, Vivek, if you can do just one thing as Surgeon General, please do something about the drug crisis in America. Wow. Because it's tearing apart our communities. And I think about them often, especially when I'm on the road.
They must be very proud of you.
Well, I'm very grateful to them because, like I said, they really helped train me and support me for much of my medical career, and that was really good advice.
And where was that?
This was at Brigham and Women's Hospital in Boston. So that was really weighing on me when I came into office. But I also began my tenure with a listening tour where I went around the country and asked communities what they wanted from our office and what was on their minds. And every place I went, addiction came up as an issue that families were struggling with. So we put together this report in order to address this crisis in America, to bring together the best possible information so that families knew what to do, so that clinicians and policymakers also had some guidance. And we really had three big goals, which is number one, help people understand the scope of the problem. Most people are shocked to recognize that nearly 21 million people in America have a substance use disorder. They're even more shocked when they recognize that that's 1.5 times the number of people who have all cancers combined.
I know.
But when you follow that up and let them know that only 1 in 10 people with a substance use disorder are getting treatment, that really blows people's minds. Because if you can imagine, if we only had 1 in 10 people with cancer who were able to get treatment, how would we react as a country?
We'd never tolerate it.
We would not tolerate it, absolutely not. And we shouldn't tolerate it when it comes to substance use disorders.
Right.
So we wanted people... So we wanted people to know about the scope of the problem. We wanted them to know that there's evidence-based prevention and treatment strategies that work and that are cost-effective. And third, we wanted people to know that addiction is a chronic illness, that it's not a character flaw or a moral failing. And as basic as that may seem to clinicians who are here today, who have been caring for substance use disorders for a long time, that attitude is unfortunately very prevalent out in the community, where many people have been either through media or through their neighbors or their family members have been led to believe that this is entirely a disease that's determined by people's character and by their choices. And while our choices do have something to do with it, we have to recognize that this is in fact a chronic illness. And that's why in the report we actually go into real detail to lay out the neurobiology of addiction, help people understand the parts of the brain that are actually changed when you develop a substance use disorder, that make impulse control more difficult, that actually impair your judgment in ways that make relapse all the more common.
All the more common.
I think for anyone who's actually tried to go on a diet or start a new gym routine, which is probably just about everyone here, you know that just making a decision isn't enough to follow through, right?
And so relapse is very easy.
Relapse is very easy. So you imagine on top of that, if your brain is actually compromised in its ability to make judgments and to control impulses, making a decision and sticking to it can be all the more difficult.
Yes. So the other, I had read, I think it was in the Boston Globe, you did a phenomenal article that really touched me about loneliness and men. And how prevalent that issue is, and the cost in someone's life of loneliness. And it's part of your focus really on emotional well-being. Can you talk a little bit about emotional well-being and how I've never thought about physicians as being connected to emotional well-being. I know that sounds awful. My son is a physician. He, of course, is an exception. But others,
Spoken like a true mom.
Exactly. how did that happen for you? And then a little bit about the loneliness, because I think it touches a lot of people.
Well, emotional well-being is a topic that has been important to me personally for a long time, but I'll tell you that I never thought that I would focus on it as Surgeon General until I started going on the road and hearing stories from people. And what I recognized very quickly was that people are in pain all across America, not just physical pain, but there's a deeper emotional pain that people have been experiencing. This is not just in the last couple months or couple of years. This has been going on for some time. And that pain, which is, I think, a manifestation of chronic stress, is really having an impact on people's health. Now, what's driving that epidemic of chronic stress? Well, it's multiple factors. We know that poverty plays a role, violence plays a role, the experience of discrimination can lead to stress, and we have far too many people in America who are experiencing that. But the experience of loneliness also is involved here. Now, we might think, well, loneliness, that's not probably such an issue in 2017 when we've got a lot of technology to connect people. But in the 1980s, 20% of adults said that they were lonely. That number now stands at 40%, despite the fact that we live in the most technologically connected age in the history of human civilization. And so why is that? Well, I think the reasons are complex, but what we do know is that people who are isolated live shorter lives. In fact, their risk of premature mortality is nearly double that of people who are not isolated. We know that the mortality impact of isolation is similar to the mortality impact of smoking or obesity, that isolation also increases your risk of heart disease, your risk of dementia, and a host of other conditions that we care about. And so as we think about how to address substance use disorders in America, I believe that we have to look even deeper to what the root causes are, not just of substance use disorders, but of chronic illnesses across the board. And when we really look deeply, we start to recognize that chronic stress and lack of emotional well-being is an important factor, an important root cause in the genesis of these illnesses. And that's why our office is building an initiative to actually address emotional well-being in America. It's a fascinating area where there's actually more science than people realize that tells us not just about the connection between emotional well-being and health, but also how we can proactively cultivate emotional well-being. And I'll tell you this, which surprised me, is that of all the issues that I have talked about as Surgeon General, and let me tell you that there have been many because our office covers a lot of ground, but the topic of emotional well-being has perhaps been the most resonant and popular one among the general public, whether we're talking to folks who are older or younger, whether they're in urban or rural areas, in the coasts or in the heartland. I think that this is a need that we need to focus on, because ultimately we don't want to just eradicate illness. We want to enable people to function at the highest level of their scale. We want people to achieve their full potential. And that's why emotional well-being is so important.
Beautifully said, really. So the people in the audience who run organizations, right, that exist in the community, is there something they could do around this issue? I'm thinking some of them have bricks and mortars, places where people could congregate. Is there a way we can begin to be more connected to each other?
Well, that's a great question, and I think that's exactly the right question to ask, which is not just what policies can we pass, what programs can we build, but what can each of us, in the roles that we play in our families and our communities, what can we do to help improve social connection and improve emotional well-being in America? And it turns out, I think there are going to be different things that people can do, but just by bringing people together to build authentic connections that are mutually beneficial, is one of the most powerful things that you can do. I'll give you an example of a program I heard of recently, which I really love, called the Experience Corps project, which brings elderly community members into schools to help mentor kids. The kids also provide some support and entertainment for the volunteers who are brought in. It's this beautiful mutually beneficial relationship, which is helping kids in school, but it's also helping older adults feel that they have a contribution that they're making, that they have a way of engaging with their community and of connecting with other people that's helping them. So that's one example. I recently, just a few weeks ago, spoke to some high school students down in Florida, in Boca Raton actually, who are created this wonderful program called, the name is something similar to No One Dines Alone. And what it is essentially a program to bring kids together in schools around lunchtime so that they don't have to eat alone, so they can be together, they can build relationships with each other. And this is one of these great situations where kids come, they may be alone to begin with, but they start feeling not only are they getting company, but they're providing company to other kids that are lonely. Again, these mutually beneficial relationships. If we can use our roles in society, whether it's our role in our family or in our workplace, to bring people together and to foster that kind of mutually beneficial connection, that can be a very powerful antidote to the kind of isolation that we're seeing right now. And it can have an impact not just on how people feel, but ultimately on their health.
Nice, very nice, and easy, right? And not that expensive, and we can each try to do something like that. I've also heard you talk about mental illness and actually, I think, a family connection to completed suicide. Would you be willing to share that a little bit with this audience?
Sure. Well, when I was in high school, I remember it was a Sunday, my parents were at the temple, and my sister and I were sitting at home at the dining table working on our homework together. And the phone rang, and I picked it up, and it was my uncle's roommate. My uncle had come from India a few years before that. He was an architect, and he wanted to come and build a life here, like so many immigrants do, and wanted to ultimately bring his family as well. So he had, he was trying to find jobs, here and there, wherever he could to make ends meet, and he was living with a couple of folks, at a home not too far away from ours. And one of the things that had happened over time is that he encountered a lot of hardship, and it wasn't always easy for him to get a job. He had some challenges around language as well. His hearing was impaired, and so that made it harder for him to communicate with people. And we know that hearing impairment is a powerful contributor to isolation, yes, among many. But we didn't realize quite just how bad this was until that phone call. And it was my uncle's roommate saying, "He's not coming out of his room. What should we do?" And because he was hard of hearing, we thought maybe he just needed to hear a louder knock. So we said, "Why don't you bang on the door really loudly?" So she did, and she said, "He's still not coming out." And that's when I started to get worried. Again, my parents weren't at home, and my sister and I were trying to figure out what we should do. And we said, "You know what, just call the police and break the door down. And we'll try to reach our parents and see if they can have any other ideas." This was a pre-cell phone era, so it wasn't so easy to get a hold of people. So they broke the door down. And they unfortunately found him too late, and he had taken a piece of rope and he had tied it around his neck into the ceiling fan. And I wasn't there to see what happened, but I know that his roommate described to me what the officers found when they broke into his room. And I'll tell you that as a young boy, maybe I was 15 or 16 at this time, that was the first experience that I had with suicide, and it's certainly the first time it had affected somebody in my family. And in the days that followed, my family, we went through the kind of anguish that every family goes through when you lose someone like that. We asked ourselves, did we do something wrong? Were there signs that we missed? Could we have intervened earlier? Did we fail him? In some way, did we fail his family? Back in India, who we had to call and let them know that this is what happened. And I grew up in a family that was actually steeped in medicine. My father is a family medicine doctor. My mother built the clinic that my father ran. But despite growing up in a medical family, this was not something that we had talked about. Yeah. And so as we think about how to address mental illness in our country and really around the world, we quickly realized that it has to be about more than changing the healthcare system and building an integrated system and passing policies that cover people. Those are all very, very important. But underlying all of that is a larger cultural change that we have to make in how we talk about and think about and regard issues around mental health. And if we can't talk about these issues, then we're not going to be able to address them. And talking about them starts at home. It starts in our communities. And that's why when I'm traveling and talking to communities, I often tell them, you don't have to have a medical degree or a nursing degree or a pharmacy degree to be able to help address substance use disorders and mental illness in America. What you need to have is a voice that can help raise conversation in your family, that can help your friends understand when the language that they're using may be unintentionally derogatory and may contribute to the unfortunate stigma that we sometimes see around these conditions. A voice that you can use to advocate also for the kind of changes that we need to see in our communities, a voice that you can use with your elected officials. So everyone has the ability to help shift culture when it comes to how we think about mental illness as a country. That was one of the lessons that I got early on in life, and that lesson has really stuck with me and has really made me feel a sense of connection to the many families all across our America who have lost a loved one to suicide.
Like opioid overdoses, it continues to go up. Sometimes, you know, I'm on the National Alliance for Suicide Prevention, and sometimes I'm almost embarrassed by it. I don't know that they would like my saying that, but, you know, we've spent a lot of time. I've been on it for a few years, and it hasn't made a difference. And I feel guilty about that, actually. I'm not here for you to treat me, obviously, but, you know, what is that about? And what do we, is there a way both on the opioid side, on the suicide side, that we can make a difference? Or is it just patience and we're all on the right track? What's going on here?
Well, I hear what you're saying about feeling guilty. When I look at the numbers and I think about how much time and effort and money we've been spending on a country on these issues and not demonstrating the kind of results that we want, I think we all should feel some degree of remorse, at least reflection, you know, about why that is the case. But it shouldn't take away from the fact that we are, in fact, we are helping people. We're just not helping enough people. And we're not keeping up with the forces that are, in fact, driving the substance use disorders and mental illness in our country. But, you know, a couple of things I think that are important. One is that if we look at how we move forward to address these issues, I think in some cases we are doing the right things. We are making mental illness and substance use disorders a larger part of our public conversations. There are more families coming forward and talking about what's happening to them, and that is a good thing. We are also starting to invest more as a country, not nearly enough yet, but more than we had been in a public health approach to addressing addiction in particular, as opposed to a purely criminal justice approach to addressing addiction. So I think that is promising. We also have more science now than we've had before that actually tells us that there are prevention and treatment strategies that work. So we are making progress on some fronts, but undoubtedly there's more that we have to do. And my concern is that if we solely look at these problems through the lens of treatment, then we're not going to ultimately get where we need to go. Because treatment is an important part of the solution, but it's necessary, but insufficient. We have to focus on prevention, and the thing is, we have to look at prevention broadly. We have to realize, as we were discussing with regard to emotional well-being, that this is not just about genetic risk factors. It's not just about one or two risk factors in your community. There's a larger series of factors that go into determining people's level of chronic stress and their level of emotional well-being. And we know that support and community support is an important part of this as well. And we have to think about how we build that for individuals and their families that are struggling with substance use disorders and mental illness. We live in a pill for every problem society, where we tend to focus on what's a new medication or medical technology that we can develop. We forget that some of the oldest medicines that we have are in fact love and compassion. And when those medicines are deployed, they can be deployed by anyone. But when they are deployed, they can provide an extraordinary source of healing that can in fact complement the modern advances that we have in science. And so we have to keep that in mind as we build solutions to the mental illness and addiction crisis, because these are crises that are, as I think of it, these are diseases of despair that are driven by deficits of hope. And so the question is, how do we restore hope to people's lives? How do we address the structural and cultural factors that are leading people to feel powerless in their lives, that are discriminated against, to be the victims of violence? If we can start thinking broadly about these problems, as many people in our country are starting to do, then we can start to address the deeper root causes that are driving mental illness and addiction.
So one of the things, you know, you mentioned, I know, beautifully said. Who would have thought, I have to tell you. You really speak with great passion, and it's inspiring. But one of the things we're certainly focused on now is medication-assisted treatment. I think it's really, we are at a tipping point. People understand it. Is it going to become an either or, that it's going to all be medication-assisted treatment and we're going to forget about the recovery supports, the AA, the NA, the places of community really that you're describing that existed long before medication-assisted treatment, that were not sufficient but may in fact still be necessary? Could you talk a little bit about how we can achieve a balance?
Absolutely, and the balance is exactly the right word. There is no single solution to addressing the substance use crisis we have in America. It has to be a combination of medication-assisted treatment and recovery services.
Yeah.
The concept of recovery is one that I worry is not well understood in our country right now. That's why we, in fact, devoted a large chunk of our report to talking about recovery and about what it entails. But it's why also, as we think about the months and years ahead, as we continue to emphasize the messages of the report, recovery is a big part of what we emphasize because people need to understand what it is. And we know that the community that's a part of recovery is incredibly important. Interestingly, it's not just important for substance use disorders, but if you actually look at chronic illnesses across the board, people often do better when they have communities of support. Because the bottom line is, changing your life and changing your lifestyle is not an easy thing to do on your own. For anyone who's attempted to get on a new diet plan or get on a weight loss plan, you know that. And it's a lot easier to do these things when you're doing it with a friend or with a community. So I think going forward that we have built a foundation now for recovery to be a part of the conversation, to be a part of the programs and policies that we develop at the state and federal level. But it's going to require a lot more ongoing education among the general public, because right now I'm still worried a lot of folks don't understand what recovery is.
Yes, even families, they immediately think of residential treatment, right? 28 days, come out, 30 days, and it'll be over. But that's not really always true. And so they need also to understand that this is a journey. It's not a 28 or 30-day solution.
That's right, and in fact, that understanding is also important to have on the payer side. When we think about insurance companies and what are they paying for, well, we know now that we have a parity law passed in 2008, which has improved our ability to cover substance use treatment. But here's the challenge, is how long is it actually covered for?
Yes.
And we're finding that there's actually a significant amount of variability there.
Yeah.
This idea that you treat and cure substance use disorders in a couple of weeks or a couple of months is an erroneous idea that's still kicking around.
Yes.
And it's unfortunately still reflected in policies.
Yes.
And that's something we have to change.
Good. That's great. So I just want to ask you a little bit about yourself. So I do know that you got your undergraduate degree at Harvard, of course, magna cum laude, in 3 years, not 4, that you got a combined medical and business degree from Yale. Medical wasn't enough. And you did your residency at Harvard, and you started a company. How did you do talk about, well-being. I mean, how did you do all that? And what is the company, is it still around?
Yeah, so well, I'll just say from the outset that I've been incredibly blessed with a lot of opportunities, and I feel very grateful for that. And I've also been blessed with an incredible family that has supported me in all the weird twists and turns that my career path has actually taken. But I'll tell you also that our story is a uniquely American story. My parents did come to this country as immigrants. I, in fact, was raised by them with the story about why they came to America, and with them telling me that they came to this country because they were looking for better opportunities for my sister and for me. The same reason that so many immigrants come to our shores. And it wasn't to say that their experience in America was perfect. Did they encounter discrimination at times? Yes. Did they encounter hardship? Yes. But you know what? They expected it was going to be hard. They didn't think it was going to be a cakewalk. They knew that they would have to put in a lot of effort to building a life that they could be proud of for themselves and for us as their kids. But they did that, and thanks to them, I had the privilege of going to these great public schools in Miami, Florida, which gave me a great education. I had the opportunity to study at good universities as well and get my medical training at good places. I had the opportunity also to begin early on in my public health endeavors, building organizations and nonprofits that worked on HIV and a range of other things. And the work I did building a technology company, which was called Trial Networks and later got acquired, that would help to accelerate development of research and clinical trials, that was also one of those wonderful benefits that came from that platform and that foundation that they built for me early on. But I sit here knowing that there are a few other countries in the world where the grandson of a poor farmer from India could be asked by the President of the United States to look out for the health of an entire nation. That's our story, that's an American story, and we're very grateful for it.
Now you're going to make me cry. This is so embarrassing. That was very wonderful. Okay. I don't think the interviewer is supposed to break down in tears. It's not the way it's supposed to go. But so many of us have immigrant stories, right? If not our parents or grandparents. I want to open this up to some questions. I have more, but I know the audience, and you've been so eloquent, and as I said, inspiring. So do we have some questions out there? And we can't see from here, so you're going to have to help us.
So I'm Vic Armstrong from Charlotte, North Carolina, home of the national champions, by the way.
Oh, sports trumps all.
So you touched on this a little bit, but we're seeing healthcare move into population health, which we further break down into community health, which forces us to then look at the social determinants and how they impact healthcare. So I'm curious to know if your office is reaching out, or to what extent you're reaching out into communities, maybe talking with mayors, educators, business leaders, about how to partner around dealing with some of those social determinants.
Absolutely. Well, I'm so glad that you asked that question, because you're absolutely right. We've been talking earlier today about some of the various factors that are driving the substance use crisis in America. And we quickly realized that these are factors that go well outside our clinics and our hospitals, but they're rooted in communities. So as we have gone on the road talking about how to address addiction in America, we have actually engaged with a lot of non-clinical, non-medical, non-public health sectors as well, including law enforcement, including employers, and educators as well as others. Because what we realize is that two things. Number one, if we're really going to build a kind of community that's important in recovery, if we're going to be able to change culture and how people think about substance use and addiction, that's going to require the partnership of all of these sectors. But there's another thing that's important for us to recognize, especially those of us who are in the medical and public health space, which is that it's one thing to recognize that all sectors have to be involved in addressing addiction, but it's a separate question of who brings those sectors together to recognize and embrace the role that they can play. And my belief is that as we start thinking about how to train health professionals for the future, that we have to train them to be those conveners, to go beyond their sector, and to recognize that as leaders, they need to bring together their elected leaders, their educators, their employers, their faith leaders, their community organizations, to be a part of that solution. People often want to be a part of the solution, they just don't know how. And if our public health leaders can be the people who draw the roadmap, who convene the players, and who move them forward in concrete actions that can result in better outcomes, then that to me is a kind of 21st century public health leader that we need.
It's interesting, Dr. Murthy, we actually have public health directors here. They had a convening here, and some of them may be in the audience, and that's a great message, I think, to them as well, as to all of us.
Well, to those public health leaders who are here, especially leaders of departments of public health at a state and local level, I know that many of you are taking on jobs with very little resources. You know that you have to be the conveners. You know that the time is of the essence. You know that there's a window where we have the attention of the country on this issue, and we have to take advantage of that to make sure that we are getting the resources to bear and getting people's involvement to address addiction in America. You know all of this. But what I hear from many leaders whenever I travel and do community town halls is that they're wondering about the pipeline. Where are the future leaders? Yeah. Are they being trained appropriately to come and staff departments of public health, to think about departments of public health as a place where you should want to spend your career? And this is where I think that we have some more work to do. Because both in medical schools and nursing schools and public health schools, we have to broaden the definition of what it means to be a medical and public health professional. It's no longer sufficient to stay within your office or your clinic or your hospital and do traditional public health work, as it were. It's important for us to expand the boundaries to see it as our job to be going to our elected leaders and talking to them about what we're seeing, to see it as our job to convene faith leaders and go to faith gatherings, to talk to communities about the cultural challenges that we face, and shifts that we have to make when it comes to addiction. These are not things that we train people to do in public health school or in medical school right now. We don't train our healthcare professionals and public health professionals in how to communicate with the public. But I'll tell you that there is a vacuum when it comes to voices right now. We live in an era where information can spread across the internet at the hit of a keystroke, and that can be the right information or the wrong information. When I actually began my tenure, it was during a measles outbreak, and I spent a lot of time talking about measles and realized just how much misinformation there was out there about vaccines. And the question again is, who is going to be that trusted voice in a community that speaks up about what the truth is with regards to science and health? And that has to be a role that our medical and public health professionals play, and we have to train them to do that.
Thank you. We'll go on.
Sure.
How about we go there,
Hi,
then back
sure.
and forth?
Yeah, thank you, Doctor, for your leadership, for your vision, for your commitment, for your call for love and compassion on stage there, and mostly for making Linda cry. So my question is, I'm heartened that the Trump administration has announced the creation of an opioid commission and a focus on drug addiction. Can you explain to us how this is going to align with your spectacular report from last year?
Sure. Well, thank you for that question. Yeah, some of you may have heard the Trump administration did announce a commission that would be focused specifically on the drug crisis that we have in America. And one of the goals of the commission is actually to gather the initiatives that have taken place within the federal government and that are ongoing, so that they can take account of what we have and make some decisions about how to fill the gaps that exist. The report that we issued at the end of last year is one of those federal initiatives, and we're certainly looking forward to working with the commission and with other partners in the administration to advance not just the report, but the larger cause. There's good news here as well, in that the issue of addiction has been a bipartisan issue in recent years. It's one of the reasons why we were able to get a significant increase in the funding for both treatment as well as prevention services. It's why there's still ongoing commitment and conversation around next steps that we need to take. So at a time where I know people worry that our country is very polarized, addiction stands out as an area where there is, in fact, bipartisan engagement and often consensus. And so I think that's a good reason for us to be hopeful.
Okay, thank you.
Mark?
Dr. Mark Fontaine from Florida. So 50 years ago, the Surgeon General released the report on tobacco. And we all know the dramatic impact that has had on how we as a country view tobacco. How do you see the report on alcohol, drugs, and health can have the same impact? What needs to happen for that to have the same impact?
Well, thank you for the question, Dr. Fontaine. If we look at the 1964 Surgeon General's report on tobacco, that was a seminal report that helped kick off a half-century's worth of work on tobacco, work that in fact helped reduce our smoking levels from 42%, where they were in 1964, to closer to 15-16% where they are today. Still a lot more work to do, but a lot of progress has been made. A key part of that success was the response of the country to the report, and specifically the grassroots response. And as I think about the report that we just issued on substance use and addiction, the report in and of itself contains key information. It is a call to action to the country, but in and of itself, reports don't change the face of a public health issue. What changes is people's response to that report. And so what we really need around the country is that kind of grassroots response that we saw in response to the tobacco report nearly a half a century ago. And what does that response look like? Well, it looks like the medical and the public health profession rethinking, for example, how they train their clinicians and their public health leaders. It looks like faith leaders responding by talking to their congregations about addiction, recognizing that many families in our communities are struggling with it, and our cultural barriers around how we talk about or don't talk about addiction are holding us back. It looks like employers asking the question, how can we make our workplace a safe place that can help direct people to help who need it and can create spaces for conversation? It looks like educators recognizing that starting early with prevention is absolutely essential and thinking about how to build these evidence-based prevention programs into their schools that we have outlined in our report. And finally, it looks like everyone, families who have been impacted and others who love them, standing up and talking to their elected leaders about what they're experiencing and calling for the sustained investment that we need in prevention and in treatment. That's what a community response looks like. That's what we need when it comes to substance use and addiction. And if we are able to build that, then I have no doubt that we can close the treatment gap, that we can invest in prevention, and that we can ultimately save many families from the pain and suffering that so many are enduring right now.
Thank you.
Thank you for being here and for your report. I'm very concerned about the fact that the federal requirements protecting, the federal requirements that insurance companies offer substance use disorder and mental health treatment are going to be lifted. And I'm wondering what your suggestions are for us as a community to help protect those.
Well, thank you for that question. Certainly we know that coverage is a very important part of ensuring that people can get treatment when they need it. And so what we have seen throughout the effort around substance use and addiction is that it is in fact the stories that people have shared with their elected leaders and with the media. It's often their advocacy as well that has helped make the case that we need to not just make sure people are covered, but make sure that these specific services are included in coverage provisions. And I think that the need for those voices is still there. So, you know, if I look out at the thousands of people who are here today, and I ask myself what percentage of this audience has picked up a phone and called your elected leader, or who has made a visit to your elected leader to share your thoughts as a public health or medical professional on what our patients need. My worry is that that number may not be all that high, but let's just test it out. How many people here have called or visited an elected leader? So a good number of people, but I'll point out that it's actually significantly less than half. Okay, so we can, if we change that, then we can make the case much more robustly that the investment in coverage, the investment in ensuring that people with substance use disorders have the services that they need, that investment is maintained and in fact increased. But that's really what it will take. You know, I said earlier that there are no simple solutions or, you know, to the challenge of addiction. And the solution is really going to involve all of us stepping up and speaking out about what it is that our communities need, and also highlighting the progress that we've made and what has worked so that we don't lose ground in those areas as well.
So you know, Dr. Murthy, they can do it right on their conference app. There is actually a button. They put in their zip code, their address, and they will be connected and can make that message. So it's perfect.
Well, that's great. Good to know.
Yes, please.
Dr. Murphy, thank you for being here with us today. My name is Fred Michel. I'm a psychiatrist and a medical director from Boulder, Colorado at the Mental Health Center in Boulder. And I have a question. I'm so intrigued by your role, and as a physician, I'm not even sure that I totally know it, but I see the kinds of reports that generate out of your role and your office and what you bring forward in terms of public health. My question is how does your role tie in with an administration? More particularly, does the Trump administration consult you or bring you into the development of policy that would affect public?
Sure.
And I'm curious. I just don't know how you get pulled in.
No, so it's a fair question. You began your question saying that there's some confusion about what my job is, and let me tell you, you're not alone. There are a lot of people who have heard of the Surgeon General because they've read my name on the side of cigarette boxes or on alcohol containers, but they don't know what I do. In fact, I often tell this story of an experience I have, like literally almost weekly, where I was getting into an airplane, and the woman in front of me in line turned around and she looked at me in my uniform. She said, "Sir, why don't you go ahead in front of me? Please, enter the plane first." And I said, "No, it's fine. I'm happy to wait my turn." And she looked around and she said, "No, without you, we can't fly the plane." So I'm used to having to clarify the role of the Surgeon General. But the role is really twofold. It's to help inform the country about evidence-based science, to help people understand what science tells us about how we can improve our health. And it's also to oversee the United States Public Health Service Commission Corps. Now, when it comes to working within the new administration, I'm one of several surgeons general who have spanned administrations. And as I was mentioning earlier in our discussion, we are fortunate to be fortunate when it comes to substance use and addiction, to be working on an issue that really has enjoyed the support of both parties, and that has been really a common and shared effort. And that is true with the Trump administration as well. And so we have had certainly conversations with new administration members as they've come into the building. We're looking forward to doing a lot more work with the new administration to advance the shared goal that we all have, which is to get treatment to those who need it and to work on prevention so that we reduce the incidence of substance use disorders in the first place.
Thank you.
Thank you. And of course, the president's brother, as I've read, died of a death related to alcoholism. So there may be also a personal connection.
That's right, and this is something that we find very commonly, is that so many people these days have a personal connection to substance use and addiction. I find more and more that I'm meeting people who are either directly affected or who have a family member or a close friend who has been affected. President Trump has spoken publicly about his brother. Governor Christie, who's leading the commission, has also spoken about one of his very close friends who developed a substance use disorder connected to opioids. I have met with many other members of Congress, both Democrats and Republicans, who have shared their stories of friends and family members who have suffered with the substance use disorder. This has become an experience that is sadly all too common. And it's part of what is driving the momentum around addressing these substance use disorders from a policy perspective, at least. And so, while it's unfortunate that so many people are having this experience, what it has done is create a common platform that people can stand on together to say, you know what, this is an area where we need to go above and beyond our traditional approaches and find ways to come together, because millions of people are suffering and we have to stop that.
Bob?
Good afternoon, Doctor. In the states that have legalized marijuana, does your office have a sense of what the impact has been in regards to substance use and abuse?
Well, it's a good question. The question of marijuana comes up very often when I travel, because we have, as you know, a growing number of states that have legalized marijuana for medicinal use and in a growing number of cases for recreational purposes. And while the story is still being written in terms of how that will impact, how the state policy shifts will ultimately impact the use of other substances and a host of other indicators, health indicators that we care about, there are some things that are important for us to share with the public that people often, I'm finding, don't know. Number one, people don't recognize that marijuana is in fact addictive, and it's in fact more addictive when you begin use early in life. Many people, I'm realizing, particularly young people, look at marijuana as something that's totally benign. And it doesn't have any real side effects, doesn't have any addictive potential, and the truth is the science tells us that that's not the case. The other thing that has been a source of concern for me has been misinformation that people have received about the quality and depth of the scientific evidence around marijuana's use for medicinal purposes. And while there are certainly components of marijuana that have shown promise in addressing a series of symptoms, there is to date no solid evidence that smoking marijuana is both safe and effective for treating a variety of medical conditions. And this is a place where we have to let science and not opinion or ideology or even anecdote drive our decision making and our policy making. But it's also one of the challenges that we have when it comes to health communications. I've often said to students who are training in medicine or public health that they have to find ways to get trained in health communications. And I say this to deans all the time as well, that we have to build that into our curriculum. Because right now, people's most common source of information is the internet when it comes to health. And the internet sometimes gives them scientifically based information and sometimes it doesn't. But we need to make sure that people are hearing from trusted health professionals in their communities about the truth with regard not just to marijuana, but also with regard to vaccines, with regard to antibiotics, and a host of other things that impact their health. And when it comes to marijuana, we have a ways to go because there are a lot of unanswered questions, there's a lot of misinformation out there. And my worry is that policy decisions are being made often in the absence of scientifically grounded information.
Thank you.
Thank you. Yes.
Hi. Hi, doctor. Thank you for being here. My name is Damon L. Jacobs. I'm a licensed psychotherapist in New York State and associate fellow with R Street Institute in DC. As a gay man growing up in the US, I was traumatized by the AIDS epidemic in the 80s. And now there's a lot of hope, and we've seen how harm reduction strategies have changed the canvas of the epidemic. Of course, my concern now is that the CDC is telling us there are 30,000 LGBT tobacco-related deaths every year. And my question for you is, do you feel that nicotine replacements, such as vaping, play a role in harm reduction and in getting those numbers down for tobacco-related deaths the way we have done so with HIV?
Yeah, so very good question, and thank you for asking this. E-cigarettes actually and vaping is a very common topic that comes up when we travel, in part because people aren't quite sure what to make of it. They don't know, is it helpful? Is it harmful? Do we not know yet? And these are questions that come up. I was actually, a couple of years ago, I was in Seattle at the beginning of my term, and I had a teacher who came to one of our listening sessions, and she said to me, you know, my kids are vaping in class. And I said, how is that? She said, well, they can't smoke in class, and they can't drink alcohol or use drugs. They can't chew gum in class, but they're vaping because we don't have any rules around that because nobody quite knows what to do.
Wow.
Now, things have since changed, and Washington State has rules, and Seattle has rules around that. And so that situation has changed, but that was reflective of a much larger body of questions that we got. When it comes to harm reduction, we have seen in other areas, including when it comes to transmission of needle-borne infections or blood-borne infections through needles, that harm reduction has in some cases proven to be an effective strategy. When it comes to smoking, we should absolutely look closely at everything possible to look for harm reduction tools. Now, is vaping one of them? Is a question. And there's been a lot of anecdotal evidence that has showed that people have said that they've been able to use e-cigarettes to quit smoking traditional cigarettes. And number one, that is just great because we want everyone to quit smoking traditional cigarettes. That is the goal here. The challenge is that if you ask the question, do we have the depth of scientific data that would prove that e-cigarettes currently are both safe and effective for cessation, that quality of data is not there yet. My hope is that as we learn more, that question will be answered more definitively. But recently we put out a report actually on e-cigarettes and youth. Now this is somewhat separate from the question of are e-cigarettes useful for cessation for adults, okay? And in that report, what we raised a concern about was the fact that we have had a marked and alarming increase in the number of kids, middle school and high school students, who are using e-cigarettes. In fact, between 2011 and 2015, we had about a 900% increase. So much so that e-cigarettes are now the most commonly used tobacco-related product among kids. And that's a rapid development in a relatively short period of time. And so we have to be able to do two things simultaneously. One is recognize that kids should not be using any tobacco-related or derived product, whether those chewing tobacco, traditional cigarettes, or e-cigarettes. And the second is to recognize that we have to let science drive and guide us when it comes to decisions around whether e-cigarettes or any other device can be useful for cessation. My concern with this area is that I worry that the debate on e-cigarettes and cessation has become very polarized, so much so that people aren't always listening to each other. On the one hand, you have folks who believe that we should absolutely be getting e-cigarettes into the hands of every smoker, that we have all the evidence that we need right now. We have, on the other hand, people who believe that e-cigarettes are the gateway to evil and we should be getting rid of them entirely. But really what we need to do is let science and not opinion guide us. And my hope is that if we take that approach, that we will ultimately be able to help people quit in a way that's both effective as well as safe.
Thank you.
Unfortunately, that was our last question. Will you come back and talk with us again?
Well, I would be happy to. And let me just say, just in closing, how wonderful it was to be here with you, Linda, and with everyone here at NatCon. I recognized when I was flying in this morning that I was going to be here in a community of people who are incredibly passionate about addressing substance use disorders and who in many cases have dedicated years and years, and in some cases decades and decades of your lives to addressing this crisis. Some of you come at this because of personal experiences. Some of you come at it because of experiences you've had with patients. But however you have come to this cause, I am glad that you are here. And I think of you as a partner in this journey, a journey that we all need to be on together. What the work that you're doing is so important, not just because you're addressing a major public health crisis, but because you are also helping us shift how we think about people with illness. For far too long, we have looked at people with mental illness and with substance use disorders as people who made bad decisions, as people who had a character flaw. What we are starting to recognize more and more is that that is just profoundly unhelpful. And that what we have to recognize is that we all are human beings who have our own predispositions and our own flaws. We are going to make mistakes. We are going to get sick. And we need to be there to actually help each other out. What lies at the foundation of this is an important value that I believe we cannot let go of, a value that states that we are responsible for each other. We are responsible for each other. And I learned this value very early on. I learned this value actually through my grandfather, the farmer, the poor farmer in a small village in India who I referenced earlier. My grandfather didn't have much in the way of education. He didn't have much in the way of money. His wife, my paternal grandmother, died when my dad was just 10 years old, leaving my grandfather with 6 children to raise on his own. And despite having so little, and when I mean so little, I mean that my father and his siblings would make dal every night, which is a grain that they would boil, and they would dilute it and dilute it and dilute it until they had enough to fill the bowl of each child around the table. Some nights it felt like they were just drinking water, but that's how tough times were. But despite that, my grandfather would spend several weeks a year traveling to the surrounding villages to raise money to build a youth hostel so that other kids could learn. Now, there were people in the village who came up to him and who said to him, "You're so irresponsible. Your own family doesn't have enough to eat. Your kids are going hungry on many nights. And instead of putting every hour that you have into earning money to support your family, you're going around and raising money for other kids. How foolish of you." And he would listen to them and he would just say to them that those kids are our kids too. That those people, that there are people too, and it's our responsibility to take care of them. And even though my parents came to this country without much in the way of resources, they passed that value on down to me and my sister, and told us that regardless of how much success we may be privileged to enjoy later in life, that we had to remember at the end of the day that those families, that those kids, that those people, that they are our responsibility too, and that we are ultimately all responsible for each other. And that's what's at the heart of the work that we are doing. That's actually what's at stake on whether we're successful or not. Because if we are going to be successful, it will be not only because we have the right policies and the right programs, but because we made that cultural shift and emphasized that underlying value that allowed everyone and encouraged everyone to step up and to step out of their traditional confines and to extend a helping hand, to change how they think about someone who has a substance use disorder, and to respond and provide that community of support that we know is so important. So that's why I'm so grateful to all of you, because you are not just helping to address addiction in America, but you are helping to reassert that fundamental value that we are responsible for each other, that will help us not only address addiction and a host of other chronic illnesses, but that would ultimately help us build a stronger country, a more cohesive nation, and the kind of community that all of us deserve. So thank you.
Thank you so, so much. It was just amazing.